right, so there's a lot of medications that we will be going over during the process of this lesson. So we will be going over vasodilators, antiarrhythmics, vasopressors, and inotropic agents. All right, so as far as nitrates goes, we will be talking about sodium nitroprusside and nitroglycerin. So I know these medications look a little bit similar, so that's why it's important to kind of know the differences in between these nitrates. So first of all, sodium nitroprusside is a balanced vasodilator that affects both the arteries and the veins. The onset for this is about 10 minutes, and we do need to monitor for thiocyanate concentration or thiocyanate toxicity. Nitroglycerin is a venous dilation in low doses, but in high doses can dilate arteries. The onset for this is a little bit faster, ranging from 1 to 3 minutes. For this, we have to monitor for unfractionated heparin resistance potential by watching the PTT with those who are receiving unfractionated heparin and nitro together. So moving on to the arterial vasodilating agents, this is something called hydralazine. We usually see this as a common IV push. There's also an oral dose of this as well. So this works to relax the arterial smooth muscle. The onset is from 5 to 20 minutes and lasts usually around 2 to 6 hours. All right, moving forward to the alpha-adrenergic blocking agents. So this is phentolamine. Now, we don't use this in our ICU, but this is important to know as a general alpha-adrenergic blocking agent. Moving forward to the beta-adrenergic blocking agents. So if you remember back to what our beta receptors do for us, right? We have beta 1 and beta 2. So we have one heart, so that's where beta 1 receptors are, and then we have two lungs. And so that's usually where we see our beta 2 receptors. So just remember that. Talking about these receptors, I want you to feel free to pause the video now, and you can definitely review back about the receptors in lesson 1 of this module. So then you are well aware of what's going on when we're talking about these medications. But just know that when we are talking about beta-adrenergic blocking agents, so it's blocking the beta-adrenergic receptors, right? So this overall results to your heart's beating slowly with less contractility, which does lower blood pressure. As far as the monitoring you have to do with these beta blockers, you need to be watching for bronchospasms, or especially with patients who have asthma, and negative inotropy with patients who have heart failure, right? So when you give these medications, it's helping the heart to beat slower and with less force. So if your patient already has heart failure, this probably isn't going to be a good thing. So as far as rate control goes, so if you've heard of medications being used for rate control, so if your patient has an AFib or something along those lines, these are medications that you can use as well. So beta blockers are actually first-line treatment for rate control in patients who are having a sort of range of cardiac arrhythmia, including atrial fib and other things along those lines. All right, so I'm not sure if you guys remember the renin-angiotensin-aldosterone system, but I really wanted to talk about this before we talked about the ACE inhibitors. So just a little bit of a back review here. So the renin-angiotensin-aldosterone system, so the goal of the system is to create this thing called angiotensin 2, which acts on the kidneys, adrenals, and pituitary gland to basically increase your blood volume by retaining water and by constricting the vessels. So just kind of moving stepwise through this picture here. So when the body senses a drop in blood pressure, your sympathetic nervous system will kick in, which is your fight or flight system, which will then trigger your kidneys, or more specifically, the juxtaglomerular cells in your kidneys, to release something called renin. And then this renin triggers something in the liver and activates angiotensinogen. And then angiotensinogen creates angiotensin 1. And then angiotensin 1 finds something called ACE, or the angiotensin converting enzyme, or this is what is responsible for converting angiotensin 1 to angiotensin 2. And then again, angiotensin 2 has effects on the kidneys, adrenals, and pituitary gland. So as far as its effects on the kidneys, it retains water and sodium, therefore increasing the blood volume. And then its effects on the adrenal gland is to create something called aldosterone, which also increases the blood volume. And angiotensin 2 also affects the posterior pituitary gland, or by activating something called ADH, or your antidiuretic hormone, which makes you retain water and sodium. So usually the system works normally and does not retain too much water. But if you're having overstimulation of your sympathetic nervous system, that fight or flight system, this is where it's important to know what ACE inhibitors. So ACE inhibitors inhibit angiotensin converting enzymes. So it prevents angiotensin 1 from becoming angiotensin 2. So therefore, you can't have that vasoconstriction or the water retention that will both lead to increasing of blood pressure. So ACE inhibitors work to prevent the creation of angiotensin 2 and therefore prevent the constriction of the vessels and helps to prevent the increase of blood volume related to the sodium and water retention that angiotensin 2 does. All right, now we can talk about the ACE inhibitors, right? Okay, so again, ACE inhibitors inhibit angiotensin converting enzyme from taking angiotensin 1 to angiotensin 2. So which again is responsible for potent vasoconstriction. So the most common ACE inhibitor I see within the ICU is lisinopril. Then moving on to angiotensin receptor blockers. So this actually blocks angiotensin 2, which is again the potent vasoconstrictor, from binding to those receptors. So these are your valsartan or your losartan. Moving on to calcium channel blockers. This is your clevaprex, your nicardipine. So clevaprex is a lipid-based medication. You have to change lipid-based medication IV tubing every 12 hours per recommendations. Do not confuse your clevaprex with your propofol. So if your patient has clevaprex and propofol, make sure you label those tubings so that you don't think your propofol is your clevaprex or your clevaprex is your propofol. And again, whenever you are having lipid-based medication, make sure that you are monitoring their lipid panels. All right, so clonidine has many different mechanisms of actions or has many different components to its mechanism of action. So basically it helps by slowing down the heart rate and reduces the amount of renin and aldosterone, which can impact your RAS system, right? Remember our renin, angiotensin, aldosterone system that we just talked about a few minutes ago, but is called a central sympatholytic agent. Lidocaine is considered a class 1 agent, as seen right here in the picture. So lidocaine is used to help with any issues in regarding some crazy rhythms, especially with heart patients. I do see this used a lot to help out with myocardial irritability. Class 2 agents, so these are your beta blocking agents that we already kind of went over. So how these medications work as antiarrhythmics is that they help to inactivate the sodium channels and therefore increasing the refractory period of the AV node. Then moving on to class 3 agents, this is amiodarone. This works by slowing down the heart rate and AV node conduction, prolongs repolarization, and intracardiac conduction. So it's important to know to not use amiodarone on heart block patients, 2nd or 3rd degree, because this will significantly impact or further reduce your AV node conduction, which is contraindicated for these patients. Moving on to class 4 agents. So these are your calcium channel antagonists or blockers. So this is your diltiazem or your cardizem. Moving on to class 5 agents. So this is adenosine. So this is a really interesting medication, okay? So I wanted to give a little bit more detail on this one. So this depresses the sinus node and AV node conduction. So this is used for SVT or reentrant tachycardias and WPW, also known as Wolff-Parkinson-White syndrome. So this definitely requires telemetry monitoring, and this does stop the heart. So look at this here over here on the telemetry. So this is an example of an EKG of when adenosine was given. Okay, so you see this crazy heart rate here, and then the adenosine is pushed. And then you have to hold your breath, guys. So make sure you're looking at the monitor. This can be the longest 3 to 6 seconds of your entire life. Just make sure, hold on, and you have to make sure they're on telemetry. So in case the heart doesn't stop, that you can restart it. But anyways, so it's the longest 3 to 6 seconds of your life. So you're watching, and then boom. And then it converts out of this achy SVT or reentrant tachycardias. So another important thing to know for adenosine is that you have to push it very, very, very fast because it has a very short half-life, 0.6 to 10 seconds. Yes, 0.6 to 10 seconds. So that's why I have a picture of a stopcock here. So typically when you're giving this, we were taught during ACLS to use the stopcock method. So you have a flush and your medication and a syringe attached. So you push the drug, turn the stopcock, and flush it through into your patient's arm. And don't be afraid to lift up that patient's arm to make sure that it gets into circulation and through the heart. So push this medication very fast. Make sure your patient is connected to telemetry when you push this, and be ready to hold on for 3 to 6 seconds, and your patient will have this nice, weird flat line, and then they will convert. All right, moving on to atropine. So this works to increase the sinus rate, AV node conduction, and refractory time. So this is an ACLS drug for symptomatic bradycardia, which is systolic blood pressures less than 90. Moving on to digoxin, this decreases SA node and AV node conduction. You need to monitor for dig toxicity with this. There is a reversal agent called Digibind. All right, getting into the bread and butter here are the vasopressor agents. So norepinephrine affects alpha-1 and beta-1 receptors. So going back to that lesson 1 for hemodynamics and the receptors, we know that alpha-1 is responsible for vasoconstriction. So beta-1, again, our memory tool is beta-1, we have one heart. So this will help to increase our contractility. This also gives a little bit of chronotropy and increases our heart rate. So norepinephrine acts on alpha-1 and beta-1 receptors, therefore leading to vasoconstriction and increased contractility and heart rate, therefore improving your blood pressure. It gives your heart a little kick too. Phenylephrine, or NEO, acts on alpha-1 receptors and is a pure alpha-1 agonist. So the effect, again, of alpha-1 receptors is to vasoconstrict. So NEO constricts the vessel and therefore increasing your blood pressure. See, now this is why I want you guys to know the receptors. It definitely helps to understand what medications you need when your patient is having specific issues. So vasopressin affects V1 and V2 receptors, and the effects of this is vasoconstriction. The nice thing about vasopressin is that it works in abnormal pHs. So if your patient has an acidic ABG, when your norepinephrine or your epi won't work, so the abnormal pH, your vasopressin actually will. All right, moving on to our inotropic agents. So inotropic agents help to increase the contractility of the heart, right? Moving on to dobutamine. So dobutamine acts on alpha-1, beta-1, and beta-2 receptors. So therefore, the effects of dobutamine are vasodilation, vasoconstriction, inotropy, and chronotropy. So overall, there's an increase in cardiac output and a decrease in SVR. So going back to SVR, that's our systemic vascular resistance. When our heart has less to work against, it's able to work more effectively. Moving down to milrinone. So this is a phosphodiesterase PDE3 inhibitor. So this inhibits cellular AMP and therefore has an effect of bronchodilation, vasodilation, and inotropy. So milrinone increases the contractility of the heart and relaxes vessels so that it can adequately pump. And this milrinone also helps to offload the right side of the heart. So if your patient has pulmonary hypertension, your physician or cardiothoracic surgeon might opt to use milrinone to help offload that right side of the heart. Moving on to our mixed agents, or our inopressors. So these are our dopamine and our epinephrine. Dopamine acts on alpha-1, beta-1, beta-2, and DM receptors. So the overall effect of these receptors are inotropy, chronotropy, dromotropy, and vasoconstriction. So inotropy is the contractility. Chronotropy affects the heart rate, so it increases the heart rates. Dromotropy affects the conductivity of the heart and then can cause vasoconstriction in higher doses. Epinephrine acts on receptors alpha-1, beta-1, and beta-2. The effects of these receptors are vasoconstriction, are inotropy, chronotropy, and dromotropy. So overall, it's important to know the receptors of which these medications work on and what the effects of the receptors are, so then you know what medications you need to correct your patient's current hemodynamic status. So if your patient's blood pressure is too high, you need vasodilators in order to open up those vessels or vasodilate those vessels. If your blood pressure is too low, you need vasopressing activity to constrict those vessels. If your heart rate is too low, you need a little bit of beta kick or some inotropy to help you out. And then to help offload the right side of the heart or to reduce pulmonary hypertension, you can use milrinone to do that. So it's very important to know what is going on with your patient, what medications act on what receptor. So then you know what to ask next for your patient if you're on 1 pressor, 2 pressor, 3 pressors, all of these vasoactive medications. So guys, if you have any questions regarding any of this information, or if you want further content on any of these, I'd be more than happy to provide it. So definitely feel free to reach out to me. Definitely don't hesitate to let me know if there's any further content on these topics that you would like me to produce for you. All right, guys, see you in the next lesson.